Hey everyone, welcome back to my channel. This is Dr. Spinach. Stop it right there. Hey friends, I have decided to make tutorials on clinical subjects based on clinical case questions. This one's about internal medicine. I hope you enjoy it. Hey, do not forget to make notes while watching. So here's our first question. A 60-year-old male patient presents with chronic cough. In addition to that, the patient has gained weight recently with development of a buffalo hump and truncal obesity. A chest X-ray revealed a mass involving the central area of the chest. Bronchoscopy is performed and biopsy of the tumor is taken during the procedure. Which of the following is the most likely diagnosis? If you see the options carefully, all of them belong to lung carcinomas. So, in order to deduce the right answer from all the options of lung cancers, we should briefly review them. Moving on to the tumors of lung. These are divided into 4 categories, which are carcinomas, lymphomas, neuroendocrine tumors, and metastasis. Metastasis is the most common type of lung neoplasm among all these tumors. Carcinomas, on the basis of histology, are further classified into small cell lung cancers and non-small cell lung cancers. Small cell lung cancers are also known as oat cell carcinomas because of the oat grain shape of their cells. On the other hand, non-small cell lung cancers are further divided into squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. Going back to our question, we now know the type of lung cancer and their category. However, bronchiolo-alveolar carcinoma is a subtype of adenocarcinoma of lung.
Dr. Spinach, can you please tell me how to approach the question now?
While solving a clinical case question, it is important that you mark the keywords while reading the question. Back to our case, we have a 60-year-old male, so the age and sex of the patient is known now, who presents with chronic cough. So this is another symptom, or you can say the chief complaint of the patient.
So, why are these important?
Because the peak incidence of lung cancer happens between the ages of 55 to 65 years. That is why epidemiology is important for us to know. Now, the patient in the question presented to us with chronic cough. So, what are the other symptoms that helps us identify the lung cancer? While cough being the most common one, the other symptoms include dyspnea, that is difficulty breathing, hemoptysis, that is blood in the sputum, along with chest pain. These patients may also present with recurrent or slowly resolving pneumonia and cachexia, wasting syndrome commonly associated with cancers. Coming back to our question, what are the other keywords we have to look for? So, in addition to that, the patient has gained weight recently, along with the development of buffalo hump and truncal obesity. All of these 3 symptoms resemble Cushing's syndrome, which we are going to discuss in a bit. A chest X-ray then reveals a mass in the central area of the chest. A mass in the central area is another key word here. Now let's jump to find out the answer.
So, what is Cushing's syndrome and why is it happening here?
In Cushing's syndrome, there is an increase in ACTH, which is adrenocorticotropic hormone normally released from pituitary gland. This ACTH then acts on adrenal gland, which in turn releases cortisol. Cortisol is a steroid hormone that has multiple important functions in our body, including increase in level of blood glucose, metabolism of fat proteins and carbohydrates, decrease in bone formation, suppression of immune system, and it also aids during stress. So, in Cushing syndrome, when there is an increase in ACTH due to various causes, it acts on adrenal gland and leads to increase of cortisol. There are three classical symptoms of Cushing syndrome. These include moon faces, that means a person's face look rounded just like a moon. Truncal obesity, that means there is a fat deposition in the truncal area of the body. Buffalo hump refers to the lump of fat that develops at the upper back between the shoulders. So, when there's an increase in cortisol levels in the body, it will lead to increase in blood glucose levels, that is hyperglycemia. Increase in blood glucose levels will facilitate the release of insulin from beta islet cells of pancreas, leading to hyperinsulinemia. Insulin functions by increasing the storage of fat in adipose tissues, and the most common location where the fat is deposited is face, upper back, and trunk. This increase in fat in turn leads to weight gain in these patients. And that is why the patient in the question presents to us with weight gain, truncal obesity, and buffalo hump. So you can question yourself, why is it happening in case of lung cancer? Cushing syndrome is an effect of paraneoplastic syndromes caused by cancers. These are distant effects produced in the body by cancer cells unrelated to the metastasis. Remember that ectopic Cushing syndrome is one of the paraneoplastic syndromes caused by small cell carcinoma of lung. So when we look back to our question options, the answer is small cell carcinoma of lung. Another hint we have here is the location of the mass. So, the location of tumor can either be central or peripheral. The tumors that are centrally located are small cell carcinoma of lung and squamous cell carcinomas, while adenocarcinoma, bronchiolo-alveolar carcinoma, and large cell carcinoma are peripherally located. Now, let's look at paraneoplastic syndromes associated with different types of lung cancers. Starting with small cell lung carcinoma. Small cell lung cancers are particularly notorious for secreting ectopic hormones. These include ACTH, that is adrenocorticotropic hormone, and ADH, that is antidiuretic hormone. Excessive secretions in ACTH results in ectopic Cushing syndrome, while increase in antidiuretic hormone leads to SIADH, that is syndrome of inappropriate antidiuretic hormone secretion. We have discussed in details about ectopic Cushing syndrome. Let's now jump into SIADH. Normally, the function of ADH is to increase reabsorption of water from renal tubules. However, excessive ADH causes an inappropriate increase in the reabsorption of water from the kidneys. This in turn leads to increase in the volume of extracellular fluid, ECF, and ICF, that is intracellular fluid. Increase in ECF results in the dilution of blood solutes, leading to hypoosmolality and hyponatremia, whereas increase in intracellular fluid causes swelling of brain cells and thus leading to cerebral edema and the complications that follow. Finally, these two paraneoplastic syndromes are associated with small cell carcinoma of lung. Every type of lung cancer exhibits its own paraneoplastic syndrome. Squamous cell carcinoma results in hypercalcemia. This hypercalcemia is due to the production of PTH-related protein. Do you remember the function of PTH? Normally, PTH, that is parathyroid hormone, is secreted from pituitary gland. PTH helps to increase serum calcium levels by acting upon bones, kidney, and small intestine. In order to release calcium in the circulation, it causes breakdown of the bones, reabsorption of calcium from kidney, and increase in absorption from small intestine. PTH-related protein has the similar effect to PTH, leading to hypercalcemia. The next one in line is the most common primary cancer of the lung, that is adenocarcinoma. This cancer is associated with migratory thrombophlebitis. Thrombophlebitis means inflammation of a vein related to a thrombus or blood clot. When it occurs repeatedly in different locations of the body, it is termed as migratory. The patients with the syndrome often presents with 5 cardinal symptoms of inflammation. The most common location are the legs. A bonus point for the exam: migratory thrombophlebitis is also seen with pancreatic cancers. And finally, the large cell carcinoma is famous for causing gynecomastia due to increased secretion of beta human chorionic gonadotropin. So, we have seen the paraneoplastic syndromes associated with small cell carcinoma of lung, squamous cell carcinoma of lung, and adenocarcinoma of lung. Additionally, the large cell carcinoma of lung. Moving back to our question, the last line says bronchoscopy is performed and biopsy of the tumor is taken. One more thing that I'd like to discuss regarding bronchogenic carcinoma is how to diagnose them. The first diagnostic tool a physician orders is a chest X-ray. Chest X-ray may show you a mass white-gray in color. If the mass is present, a chest CT scan is ordered in order to stage the lung cancer. If the cancer is in early stages, a PET CT scan may also be recommended to better locate the tumor cells. Remember that the golden standard for diagnosis of any type of cancer is biopsy, except for testicular. So the next step for confirmation of lung cancer will be bronchoscopy with biopsy.
So, what is bronchoscopy?
Just like through endoscope, we can see the inside of GIT. With the help of bronchoscope, a pulmonologist can see the inside of bronchus, that is the respiratory tract. The other tests include sputum cytologic examination, in which you can look for cancerous cells and molecular markers. And finally, fine needle aspiration. Let's now quickly review the treatment for lung cancers. The management in case of lung cancer depends upon type and stage of lung cancer as well as the general condition of the patient. These may include surgery, radiotherapy, chemotherapy, or targeted biological therapies. Discussing in details about these is beyond the scope of this video. Prognosis of non-small cell lung cancers is better than small cell lung cancers, and the overall combined 5-year survival rate is just 15%.
Dr. Spinach, are we done yet?
Yeah, kid. This completes our section on bronchogenic carcinomas. Hey friends, if you liked my video, please click on like, subscribe, and share. Don't forget to click on the notification icon. Until then, stay safe, healthy, and smiling always.